So we can go ahead and get started. Thank you for joining us for this Project ECHO COVID-19 session during these unprecedented and challenging times. I'm Petros Levounis, and I serve as professor and chair of the Department of Psychiatry at Rutgers, New Jersey Medical School, and I will be facilitating this afternoon's discussion. For anyone new to Project ECHO fosters partnerships between experts and frontline healthcare providers. It is based on education, begins with information, and extends to better outcomes. Today's session was specifically devised for frontline providers in outpatient settings. For anyone who's familiar with the Rutgers Project ECHO telemedicine clinic offerings, due to shifting priorities, we have changed our previously scheduled topics in order to focus on resources to our response to COVID-19. The topic for today's session is COVID-19 and healthcare providers, and it is going to be chaired and organized by Dr. Rashi Agrawal. I'm going to present her in a second. We appreciate all the questions you submitted upon registration. We've had tons of them. We're sensitive to the urgency of your request and are going to make any attempt to answer as many of the questions as possible on this call. The question and answer feature is also where you will be able to ask questions during the session, which will be compiled and presented to the speakers after their presentations. There will also be a significant amount of time devoted to questions and answers at the end of the session. Thank you for your participation. I hope we can have a rich discussion and ensure your patient care questions are answered during our time together. To introduce you to our technology today, if you have not already registered, we ask that you register using the link in the chat. This session is being recorded and will be distributed and posted on the Rutgers Project ECHO website after the session, including any links and resources shared during the presentation. Finally, as the timeliness of this content changes with each passing day, if you are viewing this recording at a later time, realize that this may not be the most current information at the time you are viewing it. Note that information and websites for the New Jersey Department of Health, CDC, and covid19.nj.gov as resources for healthcare providers are provided on our New Jersey Project ECHO COVID-19 webpage. And before turning it over to today's session, I just want to say that I've received several emails from our previous session on Friday, asking about psychotherapy, asking about is it okay to have a patient if we sit far enough from each other in an office, or if we have the session outdoors. And I just want to bring back the concept that it's not only how far the two people sit, it's also for how long they sit opposite one another. So the idea for us in mental health of sitting opposite somebody for 45 minutes does increase the risk of exposure, even though you may be sitting at 6 feet apart. So I answered these emails the best I could, but I just wanted to bring it up to this session as well. And with that, I'm going to turn it over to Dr. Rashi Agrawal, who's an associate professor in the Department of Psychiatry at Rutgers, New Jersey Medical School. She also serves as the program director for our residency training in psychiatry. And she has several other titles having to do with wellness and resilience in the School of Medicine. And I'm going to turn it to you, Rashi, for introducing the speakers and organizing the time that we'll have together.
Thank you, Petros. So today's session is focused on frontline workers. And we decided to do this session because a few weeks ago, we had a session on well-being for healthcare workers. And while we did talk about personal well-being and how to take care of ourselves, we also emphasized the fact that it's really an organization's responsibility to take care of us better. But the most interesting thing that came out of that session, based on the questions all of you as audience raised, was this very strong desire to help people who have been in the front line. So there was this desire to understand better what has been the experience of people who have actually been in the hospitals as a nurse, as a resident, as team leaders, and how can we help them better. So today I'm really, really excited because we have 3 panelists and we will get to hear their experiences and learn from their experience. So our first panelist speaker is Dr. Lewis Nelson, who is a professor and chair of the emergency medicine at Rutgers, New Jersey Medical School. And as you can imagine, in his role, he has led one of the hardest, most difficult departments to lead during a time like this. So, Lewis?
Thanks, Rashi, for the introduction. And I guess sort of we'll talk a tiny bit about sort of how it all began. And that's sort of a setup for where we are today and what happened in the middle. But, we were lucky in a sense here in northern New Jersey to have a prelude to what was coming. We knew what happened in Bergen County. We knew what happened in New York City. We certainly knew what was happening in Italy and Spain and other parts of the world. But despite the knowledge that it was coming, it didn't necessarily make it that much easier to handle. And there was obviously a lot of anticipation, anxiety associated with it. And what we really first saw, and I think many around the country have experienced and still have experienced, is sort of this receding waters of the impending tsunami, right? The patient volume just disappearing almost overnight, literally, so that our ED volume was down by at least 40 to 50%, but there were no patients with COVID yet. And then over the next probably week, precipitously, we started having an influx of people who were impressively sick. Even though our volume was down, total numbers, our acuity levels were exceedingly high. We were, making moment-to-moment decisions based on very limited information on how to manage these patients and trying to learn from the lessons of other places that have already done this was difficult because we were all living in a somewhat of a different situation. Our patient population's different, our hospital has different resources, our county has different resources. So it was really quite precipitous, as I said, and really hard to stay on top of things. On top of that, as everybody fully remembers, there was a ton of mixed messaging coming from the leadership of the hospital, of the government, of the state and the federal levels, not necessarily in an evil way, but in the same way that we all didn't really know what was going on. And we were sort of learning as we went. So we worked really closely together between the emergency department and the other inpatient services to develop lots of pods of different sort of healthcare providers working together as a team to be able to take care of the patients we saw in the emergency department. We built this big tent outside to keep patients out of the emergency department who didn't need to be there, and we screened them, and when we brought in people who were actually quite ill, there was this ever-present concern about the availability and the quality of PPE and what we should be wearing. And again, a changing dynamic that led to a lot of uncertainty and unfortunately to some level of mistrust, because when the message changes all the time, it's really hard to know whether you're hearing the truth or if it's somebody's filtered perspective. But despite all that, we persevered, and I think the patient volume started to peak and surge, and the workers, I got to tell you, like again, you've heard on the news, everybody stood up and did a really great job. It doesn't mean they weren't concerned and anxious and angry and all the other emotions that people get, but they more or less came to work. They more or less put on their PPE. They dedicated themselves to caring for their patients. Whether or not they suffered at the time, I think might still be yet to be seen. Obviously, some of them were sort of showing some signs of distress at the time, but most of them managed to get through that, right or wrong. And we'll have to see what happens going on. But now we're at the other end of the spectrum, right? We have no patients and we have no COVID patients. We're back to where we were before. So we're sort of regrouping on our sort of mental health and well-being issues.
Thank you, Louis. As a leader, what was one thing you have learned by trying to manage something that was so unpredictable?
Yeah, it's great. I mean, if we had to do it over again, we would have prepared better. But even, I got to say that even if we were prepared, the knowledge gaps that we had were insurmountable. This is a brand new disease. If you think about what things were like the first time we saw patients to what we're doing now, at some level, they're diametrically opposed. We used to say intubate as soon as they showed up. Now we're saying delay intubation as long as you can. I mean, we said give medications, don't give medications. It was just, everything was all over the place. So if I had to come up with a lesson learned, it would be the importance of preparing and messaging. And I guess messaging the uncertainty is very important. So people don't think that we don't know what we're doing, but rather we're responding to the stimuli as they come in. As new facts are learned, we're changing our practice, which should be viewed as a good thing. We're not just sticking to the script despite an ever-changing landscape.
You were talking about how your staff overall has done very well. Based on on my conversation with many people, I think a lot of faculty have said that one of the hardest thing was for them to have patients die in front of them with no family members. What is your take on how that experience has been for your faculty and staff?
Oh, it's exceptionally stressful. We're all people. We're all family members. We're parents. We're brothers and sisters, and we have parents. And whatever our dynamic is, we all have some perspective on this. And it is very distressing to see such anguish and such stress in people, patients, and family. I think at some level, though, we all knew we were doing what was the best thing to do. And you have to understand that doing things to people in medicine, it sometimes causes pain. But if you're doing it for the right reason, surgery is a great example. Chemotherapy, we do things that hurt people, but we're doing it for the right reasons. And there really was no practical way to have visitors, right? There really was no practical way to not cause pain in patients. It's hard. I think at some level, we are all sort of accustomed to doing these things. It was just the scale at which we were doing it that was so overwhelming. And I just don't think if we had to do it again, we could really do it any differently. We'd be better prepared for it next time. And we did, again, learn on the fly. We got iPads, we allowed communication, we got cell phones for people, but we would be better prepared if we had to do it again.
What was the hardest thing for you, Louis, emotionally, personally?
Oh, I like to know what's going on. I don't like to live in a world of uncertainty. My whole life in the ED is organized chaos. Right? Sort of like some people's desks in their offices. I just have to know where everything is. It may not always work as well as I want it to, but I have to have my ducks in a row. And I tell you, that level of chaos we were working in was just not in my cup of tea.
I so empathize with you on that one. I'm a planner, and not knowing what's happening next month or in 2 months is so painful.
Mm-hmm.
Just one last question for you. What do you think was the most helpful for your faculty, your residents, and your staff as they went through this? It was more intense than normal. So was there one thing or a few things that were really helpful for them for the emotional support part of it?
I think the collegiality that we saw both from the emergency department and from all the services in the hospital. I mean, we made new friendships with other people that, people we never saw before. And, we were fighting a common enemy. And I think there was a lot of good that came out of that. I think that the ED residents and faculty really meshed well together, and they really start to understand who has children, who has this need, who has that need. I think that was very, very important. I think one of the things that we did that did help was try to organize some conference calls and other sessions with the residents to allow them to talk and express opinions and ask questions. It gave us a chance to tell them how much uncertainty we had and what we're doing to address those things. I think, that expression that Wall Street hates uncertainty and it sends stocks off in all kinds of volatility. I think it's the same with people. It's fear that drives a lot of our bad decision making. And by trying to let people know that we're all in the same boat, that we're working, we have some understanding we're doing the best we can, I think really did alleviate a lot of that fear.
And I cheated. One last question. We talk about role modeling as a very important part of leadership. And role modeling usually means being there and doing the same things we are asking our staff to do. But with COVID-19, it was sort of upside down because we also need to role model isolation and quarantine practices. What was your balance of role modeling that you chose for yourself during this time?
Well, I worked clinically. I mean, I was there, and all of the faculty worked clinically. Nobody took time off except if you were not here for FMLA or some other reason. But pretty much everybody was here, picked up extra time, went downstairs and worked. Even when I wasn't working clinically, I spent many hours in the ED talking to people and trying to gauge, their emotional health and the needs that they had for physical and other things. So, I don't know what they'd say about how I did, but at least I could look in the mirror and say I did as much as I think I really could have done to participate and be there for them.
Thank you so much, Louis. And I know that there'll be a lot of questions coming your way from the audience. For me, as I listened to you talk, I think you really highlighted for me that, one of the organizational interventions for well-being is effective leadership. And two hallmarks of that effective leadership is not necessarily to have all the answers, but to actually have clear, consistent, and honest communication about what you know and what you don't know. And it sounds like that's what you really try to do through all this time. And the second one is really literally, metaphorically, rolling up your sleeves and being part of your team. So thank you so much, Luis. Really appreciate hearing your thoughts on this.
You're welcome. Thank you for having me.
And now it's my pleasure to introduce Denise Puente, who is a senior nurse leader who actually led a cardiac step-down unit at Huntington Medical Center. But when COVID-19 started, volunteered to actually work as an ICU nurse. So Denise.
Thank you, Rashi. I'm so glad I can say your first name. It's a pleasure being with you guys. And yes, I originally started in a cardiac step down floor and then transitioned into a clinical nurse leader role 2 years ago in a progressive care unit. I've been there 5 South for about 2 years. And yeah, when we were preparing for the surge and trying to prepare for the worst, we started creating different tiers. Our med surg nurses, our tier 1 ICU nurses, tier 2, tier 3, so that we could support the ICU staff. So I definitely did volunteer. Critical care has always been in my heart. And I said, I need to do whatever it is that I need to do, whatever it takes to help our ICU and CCU staff. So I was lucky enough to be thrown in there. And it was exciting. We got about 3 days of training. And, we were always, under the supervision of the ICU nurse and, our COVID team down there. So I always felt very supportive, just very much with the best people that I could possibly be with. But it definitely took a toll emotionally, like I shared with you during our first talk. Emotionally, mentally, physically. I'm not sure what you want me to share first.
Why don't you just tell us a little bit about how it was to work with patients who were that sick?
It was very scary. It's, working in a step down floor, we see sick, but the way that our COVID patients were presenting, nobody knew, right? I still remember our first COVID patient who crashed. They crashed so quickly, and we had to intubate him on the bedside, and that's totally, we don't do that often. Usually we're intubating them in ICU or CCU. So it happened quickly. You just had to work with what you had and just work together and know the good thing about being in this role as a clinical nurse leader, it is definitely knowing the resources. Sorry, I'm going to try to mute this. Knowing where your resources are, knowing who to call, knowing who to bring over. But that's where my PTSD started. That patient, I remember being in that room and helping the CCU nurse stabilize this patient for about an hour. It felt like an eternity. And I remember my glove broke in the room and my mask started writing down. And I started thinking, oh my gosh, I'm going to be exposed. And then you're thinking we need to keep him from extubating himself. And it was the beginning of seeing a lot of that and just, patients crashing all over and just have to run to the next fire. And then in the ICU, it was definitely, it was high pressure, high stress, high everything, but you just have to do what you have to do and put on that hat and just help, the team take care of these patients. Like Dr. Nelson was saying, there was a lot of unknowns, a lot of, what do we do? Should we do more of this? But it was an incredible experience, the hardest and the best times of my life as a nurse, for sure.
When we were talking, you had mentioned that breakdowns was almost a norm among the nurses. Can you tell us a little bit about that?
Sure. Yeah, we would be just having normal conversations, whether in the break room. I remember just hearing one of my coworkers tell me about her breakdown, the day before as she was walking into the break room to drink some water, because we're with the masks, for hours and hours, and then you need to drink water and you need to eat. And during those moments, I feel that we had a little bit of time to process, patients dying without their family members there, or just people that you took care of for a few days all of a sudden crash and now they're vented, in the ICU. And just trying to support each other the best we could, because we know we're not robots and we have emotions and we need to feel it, experience it. Unfortunately, in the ICU, I think you have a little bit less time to have that. You end up experiencing and feeling at the end of your shift. I think on the floors, you have a little bit more time because the patients are a little less acute, and, you know, you do have that time to be like, hey, I need to take a moment. But I was so blessed to have such support while I was in the ICU, that in my moments where I had my breakdowns, my first breakdown, I did have the support, you know, of a nurse. There's a nurse practitioner who saw me go into the break room, and she followed me in there, and I didn't have to say anything. She hugged me. I know it was against all social distancing rules, but she knew I needed a hug. And then later that evening, I had a true breakdown outside in the garage with my preceptor. And that day we lost about 3 patients. 2 of them were to COVID, and it was one after the other. And the first time hearing family like just wail, we did allow, you know, we had the privilege to allow for end of life situations, you know, 1 or 2 family members to come in, and just hearing them wail over their loved one, having not seen them for about 4 weeks. We had a young patient, he was 46 years old, and it was really hard. So I had taken care of that patient for a few days while I was in the ICU, and just seeing him in that room technically die, you know, alone, not with, you know, his family. It was really hard. And I broke down. I was in the garage and I was like, I just need to scream right now. And she was like, do it. And then I'm like, I just want to hug my dad. So I moved out. I have not been home for about a little bit over 2 months. And that day, my dad dropped up some brownies for us to eat because it was a really hard day, and he dropped it off and I couldn't hug him or touch him. And I just wanted to. And I told Kika that I needed to hug my dad, and she was like, I'll be your dad, and just hug me. And I hugged her, and it helped me move on to the next moment. So breakdowns are very common all the time.
What you just described sounds so emotionally distressful and painful. But when I talk to you and how you're saying, you know, it was hard, but it was also the best thing and the most positive thing. Can you tell us, like, how, like, if it was so difficult, how is it positive, or how has it helped you?
It's a privilege to be at the bedside, to be with these patients, caring for them, knowing that you are the last person that they're going to see, that the last voice that they might hear, the last hand that they might touch. And I see it as such a gift that I have had the opportunity just now, a few minutes ago, leveling another patient, and just this profession is not for everyone. And just knowing that I can be the hands and feet, and that I can be that human touch to these very sick patients, it really is a privilege. So it's taught me, I have the amount of growth, I think, inwardly, mentally, spiritually, personally, that COVID has brought, you know, in my life I can't compare it to anything else, because there's nothing like this. I've never lived through a pandemic. I've never just kind of one day become, you know, an ICU pretend nurse, you know, and just be there, do things that I would normally not do in a normal situation that we're being allowed to do because we're running out of resources and people. So it's been a privilege to take that role, just because not everyone can say that. Not everyone will ever live through this.
That is so inspiring, Denise. What did you do to take care of yourself through what sounds like a very grueling time?
I talked a lot. I talked a lot to certain people. I found my people who understood me, my preceptor being one of them, you know, my family for sure. My faith definitely has helped, just having some times of prayer, lots of crying. And then I also did therapy. I called out to just a therapist. He happens to be my uncle, and I just did a session with him one day because I knew I was going in a dark place and I needed to get out of it. and just trying to work out and maintain active and try to keep a routine in the midst of the chaos, because everything was chaotic. Every day it was a new surprise, and just being displaced, not being home, living with a coworker, and then currently right now in a hotel, just trying to find a routine, trying to find a way to still feel normal, feel like a normal human. Those are a few things.
Thank you so much, Denise. I personally found talking to you really moving and inspiring. And
Thank you.
just based on what you've shared now and before to me, I think what you really highlighted for me was some fundamental concepts of taking care of ourselves. So for you, the biggest thing was really this permission to feel and express the emotions you were feeling. And I think that's partially what was one of the very powerful things that have helped you sustain yourself. But the other two things that you had mentioned is really this connection to others, to colleagues, to family, whether physically or socially distanced, but being there. And the last one, the big one that you talked about, is really having faith in a bigger meaning, which is what you sort of highlighted for us, that this, as adverse as it was for you, and I know you're going through a lot even now, but it has been a very meaningful, growthful period for you. So
Yes.
I really, really appreciate you sharing this with us. So thank you.
Oh, thank you for asking me to do this. A privilege to me. Thank you.
Now we'll move on to our last panelist, Dr. James Schroeder, who is a psychiatry chief resident, and he not only experienced COVID-19 when there was a lot more uncertainty, because he was rotating through Hackensack Medical Center, where the first few cases, at least for us, started, long before we started getting to experience them ourselves. But as a chief resident, has also been helping his colleagues deal with it. So a pleasure to introduce James.
Thank you, Dr. Agarwal. Again, as last time, I am coming to you all from the VA, and the Wi-Fi is very poor, so I apologize if there's any disruptions, and I also apologize if I go to video only. But yeah, I think, as opposed to what Dr. Nelson was saying, where there was kind of this calm before the storm, the tide went out and they were kind of waiting and preparing before the tsunami came. At Hackensack Hospital, which is in Bergen County, the situation was quite different. And that's where the first case was, in New Jersey, as far as I know. And as I was on the consulate liaison service and in that hospital, that means that I'm in the emergency room, from 9 to 5. And I remember walking past that first patient for 2 days and not really knowing, should I even be this close? So many questions running through your head, And I think one of the things that the site did very well initially, our site director for the residents at Hackensack, Dr. Sprayosu, was immediately, she started having meetings with us where she would talk about how we were reacting to it, if concerns about symptoms we might be having. She would have us on the phone with occupational medicine immediately, so that we could be reassured, yes, I'm feeling a little achy, so on and so forth. And it's just reassuring, even though I am a physician, to have, an occupational doctor say, I think that you're fine. I think the institutional, conveyance of knowledge was good. They would let us know about how many cases there were every day. They would let us know about what they're doing. And that's very reassuring to know as an employee, and to be led in onto some of that knowledge. I think that there were certainly lessons learned, and I think that there needs to be more of that knowledge sharing, even maybe among specialties in a way that hasn't really been thought of before. One example of this is I went down to the emergency room, and this was more kind of on the upslope. So there were quite a few patients down there with COVID. And I saw that a lot of them were intubated. Not only that, a lot of them were upside down. And this was before it was common knowledge that flipping the patient over can lead to a 10% or greater increase in oxygenation. So I'm a psychiatry resident wandering through the emergency room, and I see a bunch of patients intubated and upside down. And I go to my friend who I went to medical school with, who's now an emergency medicine resident there. And I said, oh my goodness, it's like a war zone in here. I had assumed that all of those patients had expired. And he said, no, they're doing well. We turn them over and it leads to an improvement. Simple things like that, you know, things that you wouldn't think you need to communicate, but kind of came to a head during this situation. So I think communication is so important. The more, the better, from the top down. And I think it really did a lot to help us through that time.
What was the most difficult thing for you, James?
I think the most difficult thing for me was the most difficult thing for most of our residents, which was, you know, even if you're not the type of person who resorts to, you know, types of twisted thinking or cognitive distortions like catastrophization, all of a sudden in this pandemic, everyone's the kind of person who catastrophizes. So, you know, my dad is an infectious disease physician. He's fine, my family's fine. And I would always be thinking, you know, I'm in Hackensack Hospital. If he doesn't get it, you know, I'm going to get it and I'm going to bring it home to him. I live with him. And, you know, and then he's going to pass, and then I'm going to have to deal with, you know, so on and so forth. And it's very quickly, the catastrophization just got out of hand. And I think, and I noticed the same thing in a lot of our co-residents, you know, thinking, I'm going to get it and I'm going to give it to my kid. I'm going to get it and I'm going to give it to so on and so forth. And I think one of the things that you were able to do, Dr. Agarwal and Dr. Levunis as well, really quickly, which really impressed all of us, was to, I think, make drastic changes to the way that the residents were deployed and say, okay, this is different from anything we've seen before. So we need to address this more at a site level. We need to allow some of the chief residents and some of the senior residents to have more say. We need to revamp the schedule so that if a resident is in a position where they're exposed a lot, like in the emergency room, maybe they get a week off after 2 or 3 weeks working, just to relax and to be able to collect their thoughts. And also, if you're giving residents who are a little bit strung out some time off, not only does that obviously help with the physical exhaustion, so on and so forth, but it also helps them calm themselves, the catastrophization decreases, and also the contamination, and I don't mean that in a medical way, I mean that in a psychological way, the contamination of someone's negative thoughts kind of leaching into the rest of the worker pool, that also ceases if you're giving those people who are overworked some time off. So I think those changes that you were able to implement quickly really went a long way in terms of helping us.
James, but you brought up something that I think a lot of people would think about. The truth is that if you are going to be working in a high exposure situation, even with the best of precautions, there is a real risk of taking it back to family members. And Denise actually moved out of her home because of that and has been living outside of her normal family life. What is your best advice, or what do you think helped for you personally, even to handle that fear? Because it's not even just an unrealistic fear or just catastrophization. It's real. So how are people dealing with this?
Well, there are practical things that you can do, and I think most residents who are working in areas where they are seeing patients with COVID and are exposed are doing, which I did at Hackensack. You know, every day I had a separate laundry pile, come home, first thing I do, take everything off, shoes included, throw it in a separate bin, get in the shower. A lot of my colleagues are showering at the hospital and then changing there and going home. And there are practical things you can do. Now, is there evidence that that's going to help? I doubt it, but it makes you feel like you're doing something to reduce that risk. And I think that if you're really on the front lines, like Denise, and you really feel like you cannot cohabitate with the ones that you love, I think it's great that not only Rutgers, but also our other satellite institutions really went out of their way to make sure if we needed it, there was housing available, so on and so forth. And I think another thing that I think everyone should do, and Denise spoke on this as well, is therapy. I've you know, as a psych resident, I get therapy every week. And to be honest, during these times, it was hard to talk to my therapist. And I told her over the phone, I said, I really don't feel like talking. I know it's important for me to talk, but talking to you about what I'm going through is the last thing that I want to do right now. But it's so important that we make the time for that, and we push ourselves to do that, because just like exercise, you know, it might hurt when you're doing it, but you know, you're going to feel better afterwards.
So what you're saying is it was really hard, but you still actually continued with your sessions.
Yes.
James, thank you so much for sharing not just what you went through, but also strategies you took that helped you. I think we probably have a lot of questions. So Petros, we can start with the questions answers.
Well, thanks so much to all the panelists for this really first frontline report. And I just want to emphasize something that was said before, but needs to be said again, the issue of presence. All three of you were very present during the COVID, the worst parts of the COVID influx in here. And I think that presence made a huge difference to the people around you. I remember at some point I got an email that the army is here. The army is here to help us. Okay, that's great. And meet them right now at the cafeteria. So I go to the cafeteria, and the first person I see is Luis. I said, okay, all right, we're in good hands here. You know, things will be all right. Just you didn't say anything, Luis. You didn't have to do anything. You were there. So that in itself had a huge impact. And I really want to thank all three of you for your presence through all this. Okay, so we do have quite a few questions, both that were sent before the meeting and during the session now. So I'm going to start with, how did you protect students who are not employees? Rashi, you can answer that, or I can.
I was going to say, Petros, Luis, everyone can answer that. Students were pretty much taken off the site as soon as we started realizing how serious this pandemic is. So they went to virtual classes right away. It was pretty much even before the residents started encountering the number of patients. So students have started doing it all virtually.
Yeah. I hold daily sessions with the students from 8 to 9 in the morning. And I found that quite pleasant myself, but they're not allowed in the hospital. I got an email today from a student, when are we going to come back to the hospital? I said, not yet, you're not allowed. Okay, now second question, how do we address denial? Like COVID-19 being a conspiracy, or maybe being for money, or having government control? And that's open to any of our panelists.
I think in this one, different people will have varied responses. My personal opinion on this is that you don't really need to educate people about things they are not interested in for the most part. If this is a government conspiracy, great. But for all of us as healthcare workers, the issues that are sort of relevant are the issues of safety and things that can harm others and themselves. So that is the aspect we do try to address as much as we can. And that is the aspect where we can use what we normally do. We teach people about medicine based on the evidence we are aware of, and being sort of clear on, this is what we know based on this, and making recommendations based on that. Luis and Petros?
Yeah, I think that in normal times, the answer to ignorance would be data. But I think when it comes to things like this, they manage to twist even data around to support whatever perverse position they may have. And you see this happening all the time. And I guess there's sort of people who disagree, and then there's people who are actively trying to undermine a position. And I think for the people who are benignly disagreeing, they might be right, and I think we should hear all their opinions. But for the people who are actively on either end of the spectrum trying to undermine the process, I'm not sure we're going to be able to, to change that. I'm not a psychiatrist, as you all know, but I am a human being, and I live in the same world that we all live in. And I think these people are dug in, they have their constituencies, and it's going to be very difficult to fix.
I would just add to this that we have developed a lot of techniques of talking with people who have much bigger conspiracy theories that are delusional, and they may have they suffer from serious psychiatric disorders. So how do we deal with this kind of craziness in a way we can also apply it to people who may think that all of it is a conspiracy? Essentially, look at it from the perspective that they may be in such incredible fear of what's going on, and then that defense mechanism of building a conspiracy theory may be somewhat helpful to them to live through their fears and anxieties. So,
can I ask you a question, Petros?
Go ahead.
Does it depend, you know, I guess what you're describing is sort of psychiatric delusional disorders or whatever. Does that apply to people who have other secondary gain from their conspiracy theories?
That's why I would make, I like the distinction that you made. If you are in a position of power, if you're in a position of leadership, then you are not allowed this kind of kindness and sweetness that I just presented. But if you're just, a garden variety human being who comes up with a conspiracy theory, then my heart goes out to you, because I take it that you are just so terrified yourself, and I'm there to help you. Doesn't apply to major leadership, which has much greater responsibility not to go there and to take care of us and keep us safe. All right. 2 comments about Denise. Thank you so much, Nurse Denise, for sharing such a heartfelt and honest recount of your experiences. And from another person, Denise, the ICU nurse, the story is so inspiring. I'm curious, how come you only had 1 session with a therapist? What were the barriers for you to continue treatment? Frontier workers are hard to wrangle to engage in treatment, and as a therapist, I'm hopeful to learn ways to better connect and engage with frontline workers.
Sure. I was afraid I was going to be asked this question. So I'll go back to what James shared. There came a point where I just did not want to talk anymore. And I think that's the way for me to cope, which is a horrible way to cope. I just didn't want to talk about it. I was trying to find other ways to cope. And soon after, I realized that I really, did need more therapy. And it's just been excuses. And I think just because life has been very chaotic and, having to find a different place to live and everything, I have not prioritized that second therapy session. But I definitely can when James said that, it was really, that's the reason why. You just get to a point where you just don't want to talk about it anymore, even though I know it would help me. You just don't want to deal with it.
Actually, to make it harder for you, Denise, what people probably don't really know is that you didn't even go to a therapist. You spoke to an uncle who's a therapist, so you didn't really seek formal help. I don't know if you can say something about is there something we as therapists, as counselors can do that would make it easier for people who are in your position to actually get formal help?
Sure. So I did, go to him because because he's known to me. I know his style, and he actually lives in Ecuador. He doesn't even live here. So it was very convenient that we could Zoom. I think I've had therapy before, and just the technique or the way that certain therapists are, at least the ones that I've used, it hasn't really helped me. So I know his style, and a huge part of my coping and my, my way of dealing with this is related to my faith. And I know that he's also a man of faith, and I felt like I was going to connect with him better. That's the reason why I went, towards him. But I definitely have had other therapists, some okay, but some not too good. So I needed something quick, and I knew that he would be available to do it.
Denise, if I can add to this, the issue of having therapists who are family members or friends and loved ones, I do get asked sometimes from colleagues or other friends to give some advice or to take them in as patients. And I do give advice, but I don't take them in as patients. That's how I've resolved this issue for me. I don't charge, of course, and I'd be more than happy to have a conversation and help the best way I can. Once and only once, with a very dear friend of mine, I decided that it would be best for him to do it very formally because of him, basically. So he paid the full fee. He would come exactly at the right time. We had very, very structured sessions, and I think it turned out quite well. I know it turned out well, but the distinction has to be made in some ways, for me at least, whether now is this a formal psychiatric session or this is more of an informal counseling and advice that I give to loved ones, colleagues, and so on. All right, we have another question here. How do we prepare for round 2 of COVID-19 in case there is any? How do we address the unknown? When's this going to be over? What's the next step?
I can address some of that. I mean, certainly I can address the processes that we deal with. I'm not sure I could address the psychological and other well-being issues, but we learned a lot. And I don't doubt that we will be much better prepared for a second wave of this coming in. As, again, most have seen, the models don't tell us what's going to happen very well. There's too many unknowns to feed the models. It's possible we'll have little blips that go along for a long time. It's possible we'll have a big surge. It's possible it'll go away and we'll never see it again. I mean, it's really hard to know what's going to happen. I think we are prepared for the worst and we hope for the best. We're stocking up on PPE. We have our ventilators in place. Our teams that we've created before can be recreated again. We do have some physical limitations, such as the number of beds in the hospital and the emergency department, which we can't fix. We built some of these off-site medical care facilities, like in Secaucus and at the Javits Center and in somewhere in Mid-Jersey, I forget where, but Edison maybe. But we, we can reconstruct those, but that level of knowledge we just will not have until it happens. We do know better about medical care, and we're continually learning. We went through the remdesivirs and the hydroxychloroquines and the IL-6 inhibitors and prone positioning, as was discussed. We're learning where these things fit in medically. Obviously that has not been solved by any stretch of the imagination, but we're continuing to learn. And the ultimate, ace in the hole right now is, will there be a vaccine or a really good prophylactic or therapeutic drug to treat this disease? So again, we are preparing. We do have a lot more knowledge than we did the last time, but I don't think we should think that this is a done deal and everything's going to be well. This won't just be sort of like, a little measles outbreak that we isolate a few people and it all goes away. This still has the potential to be quite devastating.
If I can add as well, Dr. Livunis,
Yeah.
I think this is a great time for providers to become established with a therapist. And, this is something that I've been telling the psychiatry residents and some of the emergency room residents and some of the medical residents for a long time. It is possible to find a good therapist and establish a relationship relatively quickly in a time of need, but it's much easier to forge that relationship when you are not, feeling like you are acutely at risk. And, sometimes, like Denise was saying, you meet one therapist and they just don't gel with you. And even if they're going to gel, it's going to take some time for you to get to a point where you can really trust that person and you trust that that person has your best interests at heart. And so now that we're kind of in this lull, even though it seems kind of counterintuitive for many providers, I think now is the time to find someone, get established, learn to trust them, learn their style, so that should this, strike again, you have someone who can kind of guide you through and who knows how you think and who can anticipate, the maladaptive ways in which you might try to cope with this. So I'm really we're becoming kind of evangelists with that. And I know that some of the residents in my program, Donia Nazari, through her, her project to help other residents vent and then transition them eventually to more sustainable mental health resources, I think it's pretty important that we follow through on that.
I would like to second what James just said. Uh, it is really, and maybe also refer back to the session we just had 3 weeks ago on well-being. This is a time to build upon your well-being and resilience, because times of uncertainty are the hardest. They're sometimes even harder than the actual acute crisis. And in some ways, we are now in a limbo. In New Jersey, we are doing much better with the cases, but we really cannot predict what's going to happen in the next few months. So we really need to harness all the well-being strategies and figure out which ones work the most. And as James is highlighting the need for therapy, but what we're sort of talking about is how we all deal with uncertainty. We all have difficult emotions that come up, and how do we manage those, and what kind of defense mechanisms we use subconsciously, consciously, and what do we want to use. So I would also encourage you to refer back to the session we just had a few weeks ago.
Just want to say that we've got some comments here that therapy works best after the crisis, not during the crisis. And there are some arguments about that, and we've heard about some of these ideas. I'm looking at the time here, and we have about less than 10 minutes left, so I'm going to take some questions really quickly here. We have a few questions about EMDR. And the EMDR is an eye movement therapy that was very popular after 9/11 in terms of disaster psychiatry and disaster response. It has not been as well studied as we would hope. I have to say, we're more skeptical about EMDR after 9/11 than the evidence turned out to be. There were more good things about EMDR than we thought. We thought it was totally outrageous and there was absolutely nothing to it, but we found that there was something to it. But unfortunately, it was not followed by a rigorous scientific study. And so if anybody else has any comments about EMDR, please go ahead. All right. Now, next one is about how do you deal with disruptions in sleep? We're mentioning that sleep hygiene and good sleep is probably one of the most critical parts of physical health, and the most underestimated, underappreciated one. I'm going to give the most specific advice I can have here, and that is wake up the same time every morning. Not necessarily go to bed the same time every evening, but in terms of improving your sleep, make sure to get up at the same time every morning. If anybody has something else to say about sleep, let's go ahead.
Well, I would offer that a lot of sleep is, sleep disorders is anxiety related. And, I think exercise is very helpful, and, other physical activity to sort of help you sort of think through some of your problems that way. And obviously, if falling asleep is difficult, I'm sure that we've all thought about different ways to sort of, maybe this is the wrong word to say in a psychiatry group, but to sort of trick our mind into thinking that we're okay so that we could fall asleep easily, count sheep or whatever it takes in order to get ourselves to sleep. Because sometimes falling asleep is the hardest part. And once you're able to do that, you do okay. But I mean, I do second your idea. Petros is trying to create something that's consistent. I think that helps too.
Something that's helped me, if I can share, is the working out and also not eating too late and disconnecting from my phone a few hours before, because I know that it's very common for us to just lay down and be on our phones, and that definitely keeps me awake longer.
My partner Shannon takes away my phone 2 hours before bed, and the only electronic device I'm allowed to use in that window is my Kindle.
Okay.
One quick last one, voluntary breathing exercises. So just paying attention to your breathing and counting the breaths. It's sort of what, like Luis was talking about, tricking your mind with the sheep, but this actually calms your system down. It stimulates your sympathetic nervous system, and it is relaxing, and it will help. And the more you practice it, the more you'll be able to actually use it if you're having difficulty sleeping.
All right, the question now for Luis. Since COVID-19, has there been a change in the number of patients being brought to the emergency department for opioid overdose?
Absolutely. It's actually been quite fascinating. There is not only have there been a marked reduction in the number of people with opioid overdose, we've had a marked reduction of people with opioid withdrawal. So you would think that the two would sort of move in opposite directions in a way, right? I mean, if there was not enough opioid available that people were overdosing, they would be withdrawing. Yet we haven't seen either of those. And there's a lot of theories about why that is. When you do talk to people that have overdosed, they'll tell you that the drug that they're getting isn't what it usually is. So presumably either they're diluting it further or the quality's fallen. Maybe it's been harder to import fentanyl from other places, but clearly the drug itself is not what it used to be. On the other hand, they tell you that there's a lot more buprenorphine available on the street, right? Perhaps because an unintended consequence of the changes in liberalized buprenorphine use through telehealth and other mechanisms. And when you call this sort of diversion as a harm reduction program or whatever you like to think about it, maybe the people who can't get their good quality opioids and developing opioid withdrawal are actually spontaneously using buprenorphine. It's a little hard to know. Now, the other possibilities are all dying and we're not seeing them. Right. And we don't know because unfortunately, in the current state of affairs, there are far too many decedents for the medical examiner to do posts on all of them. So we have a tremendous deficit in why people are truly dying. So some of those patients are, out there, maybe being called presumed something, but not necessarily being labeled as opioid as a cause of death. Maybe they would diagnose a heart attack or stroke or this or that.
Yeah.
I think from an outpatient perspective, at least within our buprenorphine clinic, is that a lot of our patients who may be homeless are staying with their family members instead, like their children, and they have a watchful eye over them. And that, really helps them to, I guess, realize it's almost, and then potentially not use or, go out in the, on the streets and, obtain their normal course of drugs, or it basically breaks away from their routine from that.
Okay.
Yeah, and I can just say one final thing. They're back. They're back. We had a marked upsurge in the number of opioid overdoses we've seen in the past couple of days, maybe the past 2 weeks or so.
All right, we are coming to close to a close, but before doing that, as a segue to next week's presentation, we're going to answer one more question from a rather insistent person who has written a couple of times and said that what happens when you have a 7-year-old kid whose parents are both physicians, they need to be at work, there are no other family members to take care of the 7-year-old. It's an important situation. I would like to know the answer. I'm saying that this is a prelude to next week's session because next week we'll have Dr. Cheryl Kennedy, who specializes in child and adolescent psychiatry, and will give us a talk on children, adolescents, and families in the context of COVID-19. But I don't want to leave this question unanswered. So if anybody has any ideas about that, what do you do with a 7-year-old whose parents are both physicians and they need to work, but there are no other family members to take care of the kid?
I can only tell you that, we face this here and other places in the emergency department, and it very much depends on the family, honestly, the family structure. Some people have felt comfortable, as James did, taking off their clothes and taking a shower and socially distancing at home and even wearing a mask and making sure you keep your hands clean, and just persevering and doing it. And others have gotten to the position where only one of them is going to go to work, just like in many other households, and somebody stays home with the kid.
All right, I'm going to stop you there, Luis, because we need to stop exactly on time. I have some closing words here. I want to thank our panelists, thank Rashi for organizing all this. And this session has been recorded and it will be made available at the New Jersey Project ECHO COVID-19 webpage. We'd also like your feedback regarding your interest in participating in subsequent sessions of this subject. Please take a few moments to complete our post-session survey so that we can gauge your interest and plan for upcoming sessions. Next session is next Friday at 12 o'clock. Dr. Cheryl Kennedy is going to be our presenter, and I hope you all come back and join us. Bye-bye now. Come on, wave. Everybody has to wave. All right, bye-bye. Louis, you too. Good. Bye, everyone.